invite Dr. Rocha-Singh back up to the podium. He's going to talk to us about some novel endovascular management for patients with resistant hypertension.
Good morning, and I hope you had a restful evening. I'd like to take you on a brief journey. I think a brief journey that will, in the years to come, be chronicled deeply and widely in both business school books and in physiology books in medical school, and our textbooks that we read as cardiologists and physicians, vascular surgeons. And it's a good dovetail into Dr. Martin's comments, because I was talking to somebody about renal stents, and as you know, what's happened to renal stents is sort of what I suggested yesterday, is that the government has gotten hold of some of the poor science that is in the clinical space and has put a lot of economic pressures along the lines of carotid stenting. And so with that some of the background, these are my disclosures relative to what I'm going to be talking about, and specifically renal denervation. I was an uncompensated, much to my chagrin, consultant to Ardian. So what I really want to talk about is the pathophysiology of resistant hypertension, and suggest to you that as endovascular specialists, you will be seeing a lot of these patients. You already do, because they come to you to rule out renal artery stenosis, and they don't have it, and then what? It goes back to optimal medical therapy, which in my lecture I will suggest to you is probably greater than 50% of the time suboptimal medical therapy. I'm going to use that as a platform to talk about the hypersympathetic state. And as cardiologists and vascular surgeons and clinicians, we deal with this every day. It is the basis of many, many things that we treat. And we now have access via percutaneous renal nerve denervation, RDN, hence the name of the company, Ardian, for the procedure. And then finally, talk about future applications. Because as I suggested, this therapy will be deep and wide with regards to what it can do for our patients. So I would ask Dr. Martin what he would do with this patient. This is a patient that was referred to me and was put into clinical trial. A 34-year-old white woman, first thing you think about, okay, FMD. Well, of course, that's ruled out real quickly by the general internist with a CTA. There is no renal artery stenosis after they get a hold of me. And electrolytes, urine catecholamines are all negative. The patient really is on optimal tolerable, and I think that's an important word to add to optimal medical therapy. A lot of patients cannot tolerate or won't tolerate a lot of these medications. This patient was on 6 medications: beta blocker, ACE inhibitor, spironolactone, a diuretic, and then a direct renin inhibitor. The book was thrown at her. She's a young woman. What do you do with this woman now? She, I would suggest, if you believe the Framingham data, would have a significant decrement in her life expectancy with regards to absence of morbid or mortal CV events. Well, as Dr. Martin suggested, this is what happened to renal stenting. I think we could have a sidebar conversation on my perspective of how radiology got into this, but obviously there was a lot of renal stenting, much to chagrin of a lot of people. And after AHRQ was alerted to, these cardiologists going up and down the abdominal aorta and shooting bypass angiograms and stenting renal arteries indiscriminately, I'm being very provocative, obviously. This is what's really happened to renal stenting. I can tell you, in my busy practice, I've stented 5 renal arteries this year. Internists, after they got a hold of the data that was out, published by AHRQ, and remember that's a 4-letter word down there, and they're going to be becoming more important in your life, published basically an assessment that suggested, renal artery stenting, there's a lot of it. We're paying a lot of money for it. We're not sure it's any better than medicines. They did a study. They commissioned a study, and they suggested there were no good studies available to support renal artery stenting. And so, again, they said, 2/3, bottom line, of the studies were poor methodological quality, and shame on industry, shame on doctors for allowing this to happen. We only have to blame ourselves because we did not do our homework to do these type of trials. Coral, hopefully, will come out. Further battering has occurred as a result of the Astral trial and the STAR trial, which I think relative to Dr. Martin's comments yesterday, a randomized controlled trial can be poor science, likewise, as I believe Astral was, and there will be problems with Coral, no doubt, because of selection bias. So let's talk about the problem that we still have. The problem is that hypertension is growing, and in the next quarter century, look at these rates here. This is in the millions. Look what's going to happen in China. Look what's going to happen in sub-Saharan Africa. Hypertension is going to grow. There's no doubt about it. And look at the persistence of hypertension, getting to Dr. Martin's point, of patients who are on a variety of medications over time. These patients either become resistant to the therapy, but persistence. There is inertia in treating many internists. They say, give it to the cardiologist or give it to someone else. We don't want to deal with this. For a multiplicity of reasons, patients are not treated well for blood pressure. But even if you're in an NIH trial, even if you're in a drug trial run by a CRO and funded by drug companies, the number of patients that reach goal is, as you can see here, sometimes a flip of a coin. So why is this? Are there therapies that we just can't understand, or we're not penetrating the underlying physiologic method or pathophysiology? And that's what I want to spend the following time discussing. And I really believe it's hypersympathetic activity that is the basis of dysrhythmias that we as cardiologists treat every day: atrial fibrillation, ventricular tachycardia, renal disease that I think these hypersympathetic states feed into and cause progression of renal dysfunction, and insulin resistance. Believe it or not, we'll talk about how insulin resistance, I think, relates to a hypersympathetic state. Heart failure, obviously, diastolic dysfunction, obesity, obstructive sleep apnea, but we're going to start with the low-hanging fruit, which is resistant hypertension. And how in the world can we start thinking about resistant hypertension and the sympathetic system? Well, the clinical science is deep and wide with regards to what surgeons have been doing all the way back to the late 1800s, and understanding the innervation of the renal vasculature. It plays a key role in hypertension, and that renal sympathectomies done in the past resulted in a cure of resistant hypertension. It also killed a lot of patients, and it also made them have severe orthostatic hypotension, but it took care of their blood pressure. So we understand that renal sympathetic afferents and efferents, if you can innervate them, it will reduce renin release, sodium retention, and reduce renal blood flow. If you look at afferents, these are nerves sending up to the brain, and you understand that those then feed back on the heart, increase SVR, and reduce renal perfusion. Denervation of afferents potentially could attenuate the renal's contribution to centrally mediated sympathetic activity. So if you think about this, if this is a freeway, and it's a two-lane freeway, and it's going back between the kidney and the brain, if you can put a roadblock there, what could potentially you do to deal with the pathophysiology that evolves with the heart and renal resistance and hypertension and renal dysfunction? It could be substantial. And so the physiologic positive feedback in this hypertension really is very important. And to Dr. Martin's provocative statement, could we cure hypertension if we got these patients early enough with substantial hypersympathetic tone? That's a very provocative statement, obviously, that I'm not going to be able to answer this. As baseline for my further comments, we can quantify human sympathetic activity by looking at muscle sympathetic nervous activity, by putting microneedles in the perineal nerve, and we can actually listen to the system, if you will, and we can count the number of bursts per second. We can also do something called norepinephrine spillover, looking at how much norepinephrine, tritiated norepinephrine, goes into the kidney and how much comes out, or how much goes into the heart and how much comes out. And so we can get an assessment via these two surrogates of really how active things are. And look how active things are. Look at these studies. If you look at heart failure class 1, 2, and 3, and you look at muscle sympathetic activity, you see how revved up the sympathetic system is in these patients. If you look at patients that you and I treat every day, hypertension with an H, obesity, heart failure, and you look at sympathetic nervous activity as they become combined, I frankly see a lot of fat people with heart failure and obstructive sleep apnea. And look at this. Look at their hypersympathetic activity. So all of a sudden we have an opportunity to potentially treat not only hypertension, but maybe obesity, maybe congestive heart failure. How could we potentially do that? Well, as it turns out, the sympathetic nerves reside in the adventitia and the deep layers just outside the kidney. And many of you have seen this slide. This catheter, second generation catheter, can apply a small amount of radio frequency energy, approximately 8 watts, and hopefully ablate these nerves. This is a very relatively simple technique. This is a sort of an AP flexible catheter. This procedure is done in 40 minutes. Outpatient procedure, I believe, ultimately. It's done in 4 treatment areas bilaterally. I'm just going through these very quickly because this is not about the procedure, I'll tell you. Any well-trained endovascular interventionalist can do this. It makes renal stenting really, this is no challenge at all is what I'm saying. This is the way it looks afterwards. You do it bilaterally. Some of these patients will have visceral pain. But then we have what this company did, flying under the radar, going down to Australia, and basically did a FIM, and did a FIM fairly quickly, looking at catheter-based renal denervation, and basically showed that we know now that this is very safe and it's very effective with 2-year follow-up via this trial, the FIM, looking at this. Now, no one, not even AHRQ, is going to moan and groan about a 33 millimeter drop in blood pressure. And if you do a randomized trial that is both statistically significant, and I would believe if you followed this up clinically relevant, you see the same thing, a 32 millimeter drop in blood pressure in these patients at 6 months. This was a crossover trial. I do not believe this will ever become an NIH trial because I think doctors will believe it'll be unethical to subject their patients to protracted medical therapy for 5 years to find out if they'll have a stroke or a heart attack or progress to renal dysfunction. Now the questions are, will these nerves regrow? Is this going to be something that's durable? We have information now out to 12 months, soon out to 24 months, that this is a durable effect as measured by muscle sympathetic nervous activity. So the hope is that this will potentially, I'm not saying potentially, be a cure. And is it durable? And we're going to find that out, I think, in the days and months to come. So we're going to have some unsolved questions and challenges. Can we predict non-responders? 10% in the randomized trial did not respond. Could we do this before? Could we pick those patients out and say, hey, renal denervation is not something we're subjected to? We already know in our practice, when we were in this trial, clonidine, a 2-week trial of clonidine, predicted those patients, frankly, who would be able to sustain an event. Again, is it durable? If we get these patients early, could it be a cure if they have hypersympathetic activity? And what are the anatomical limitations? This catheter can only be done in renal arteries of a certain size, a certain diameter, and a certain length. Those patients in the randomized trial were put into a registry, and only one side was treated. So we understand that, again, there are going to be other anticipated benefits, as I suggested, and here's one of them. There are at least 4 signals. I'm only given 15 minutes. This is really an hour talk, but this is one thing that I think is going to resonate with a lot of you. Look at its effect. Look at its effect on glucose. And here you have the old glucose tolerance test, and you look at 1 minute, 60 minutes, and 120, and you can see when re-administered at 30 days and 3 and 6 months afterwards, the decline in the response to the glucose challenge. If you look at fasting glucoses out to 6 months in the same cohort, you can see a decline in their fasting glucoses along with C-peptides and insulin. So why could that be? Well, that's another 10-minute talk about how sympathetic denervation shunts blood out of the viscera, where metabolism of insulin is not as complete or efficient as in the peripheral muscular vasculature. So what about the competition? As you can imagine, for some of you who may not understand, this company was purchased for $1.3 billion, the most ever paid for a single device, and you can imagine there are going to be a lot of fast followers. And here's the first one into my last 30 seconds. This is a 510K device that has a micropuncture needle on it, and these people are moving fast. This is a true startup. They actually ripped off the images from the other company as part of their presentation. That's a definition of a startup. They don't have any, they don't have people to pay for their art. So you basically do a micropuncture and you inject guanethidine. Guanethidine is an approved drug. This catheter is a 510K device. The possibility of them getting into a first-in-man trial in the United States is significant and be a very, very fast follower. This is what it looks like when you inject. The needle goes up, the balloon goes up, the needle comes out, and you actually give the guanethidine into the adventitia. Now, as a cardiologist, when I first saw this and I was in their lab, I must admit I had a conniption. I said, this is something that a cardiologist or a radiologist would be saying, reverse the heparin, give me a stent graft, so forth and so on. I can tell you they've proved this to be safe. And they've also shown that if you look at the histology, this is the final. They give 2 treatments. If you look at the histology, there is evidence at 24 hours and at 30 days that you are actually able to ablate these afferents and efferents. And here's the longer-term follow-up with these H&E slides looking at the degradation of these neural cells, again, at 28 days. And at 28 days, the proof of concept relates to this. Here is the proof, in animals at least, that this denervation results in a decrement in norepinephrine level in pigs. So there will be, I think, a lot of fast followers. We have to ask, will denervation be durable? What are the expanded indications? And I can tell you beyond hypertension, there's going to be glucose intolerance and diabetes and obstructive sleep apnea and renal insufficiency and obesity, and those signals are already being had. And then obviously the next generation catheter, and finally the competition is coming real fast because this is a billion-dollar market. So I invite all of you to stay tuned. Thank you very much. This is a patient that was referred to me and was put into clinical trial. A 34-year-old white woman, first thing you think about, okay, FMD. Well, of course, that's ruled out real quickly by the general internist with a CTA. There is no renal artery stenosis after they get a hold of me. Electrolytes, urine catecholamines are all negative. The patient really is on optimal tolerable, and I think that's an important word to add to optimal medical therapy. A lot of patients cannot tolerate or won't tolerate a lot of these medications. This patient was, some of the background, these are my disclosures relative to what I'm going to be talking about, and specifically renal denervation. I was an uncompensated, much to my chagrin, consultant to Ardian. So what I really want to talk about is the pathophysiology of resistant hypertension and suggest to you that as endovascular specialist, you will be seeing a lot of these patients. You already do, because they come to you to rule out renal artery stenosis and they don't have it, and then what? It goes back to optimal medical therapy, which in my lecture I will suggest to you is probably greater than 50% of the time suboptimal medical therapy. I'm going to use that as a platform to talk about the hypersympathetic state. And as cardiologists and vascular surgeons and clinicians, we deal with this every day. It is the basis of many, many things that we treat. And we now have access via percutaneous renal nerve denervation, RDN, hence the name of the company, Ardian, for the procedure. And then finally, talk about future applications. Because as I suggested, this therapy will be deep and wide with regards to what it can do for our patients. So I would ask Dr. Martin what he would do with this patient.
invite Dr. Rocha-Singh back up to the podium. He's going to talk to us about some novel endovascular management for patients with resistant hypertension.
Good morning, and I hope you had a restful evening. I'd like to take you on a brief journey. I think a brief journey that will, in the years to come, be chronicled deeply and widely in both business school books and in physiology books in medical school, and our textbooks that we read as cardiologists and physicians, vascular surgeons. And it's a good dovetail into Dr. Martin's comments, because I was talking to somebody about renal stents, and as you know, what's happened to renal stents is sort of what I suggested yesterday, is that the government has gotten hold of some of the poor science that is in the clinical space and has put a lot of economic pressures along the lines of carotid stenting. And so with that